So the topic of today's talk is what's fundamentally wrong. So I'm going to start off, and I want the theme of today's talk is what is wrong with the way we think about diabetes and what is wrong with how we treat diabetes. And of course, I wouldn't be complete if I told you these things and I didn't tell you how we can address those. So I want to put us on the line by playing a game show here. Except this is some kind of bizarre game show. And today, Wayne is going to ask us to pick a bizarre choice. We have to pick a choice here, okay? And he's going to put us in a time machine, and we're approximately 20 years old. And we have to pick either we're going to have type 1 diabetes or type 2 diabetes. Now, I want you to think for a moment. Which one would you pick if you had to pick one? Okay? Bad choice, but think about it. Think carefully. Which one? Okay? Now, I'm not going to ask you what it is just now. Everyone have one in their mind? Okay. So now it's 20 years later, and here's the result. Okay. How many of you picked the right choice? I'm going to see a show of hands. Raise it up higher. Okay. All right. This is the right group. I'm glad. Actually, glad to see this. It's better to have picked type 1 diabetes. Type 2 diabetes is a much worse disease. And it gives us a way of thinking about the difference between the two diseases. The two diseases are similar in many ways, right? Similar in many ways. And yet, type 2 diabetics in this study and many subsequent studies have shown that type 2 diabetics have many of those bad things that we worry about. They unfortunately had a higher mortality rate. They suffered from kidney failure, eye problems, all those things we worry about with diabetics. So what's the main difference? The main difference is insulin resistance. Now, we're always told about glycemic control, right? Glycemic control. But the difference, and the main difference between a type 1 and type 2 diabetic is this, insulin resistance. Now, insulin resistance for many people, including diabetics, is a new topic. Many of you have not heard of the term insulin resistance. And today, I'd like to bring it to your attention as something that we need to pay dear attention to. So, the type 1 and type 2 diabetics, at the final last stages in which they are insulin dependent, when they're all injecting insulin of some sort, they have low insulin production. But the difference between a type 1 and type 2 diabetic is a type 1 diabetic actually can live a normal lifespan. They can live a normal lifespan if they keep their insulin resistance low. Keeping insulin resistance low is very important. The type 2 diabetic gets to a low insulin production through increasing insulin resistance. That's the difference. That's the mortality. That's the difference in complications between a type 1 and type 2 diabetic. The type 2 diabetic has high insulin resistance. Okay, so this is a diagram. Don't worry, we'll walk through it very carefully, very slowly. A lot of this is familiar with you. So if you look at this line here, this is the glucose level. And this is someone with normal health and on their way to type 2 diabetes. So, in the beginning, everyone starts off with a normal glucose level. And slowly during this time, it rises and rises. Until which point, they maybe take a test and their doctor tells them, well, you have prediabetes, right? Or maybe you have gestational diabetes. And then glucose level goes up, and then you become diagnosed with diabetes. Everyone's familiar with this, right? Okay. So, I'm going to tell you the other half of the story. The other half of the story is that this is insulin. This yellow line is insulin. So insulin, during this time, has been rising, rising, rising. And during this time, it's been rising, and we didn't notice it because our glucose levels have stayed the same. So we don't measure insulin normally. But during this period, insulin has been getting higher and higher. And before we were diagnosed, even before the diagnosis of prediabetes, insulin started to fall in type 2 diabetics. It began to fall because the cells that make insulin, the cells in the pancreas are called beta cells, have been overworked. They've been trying to increase their output of insulin, and they couldn't keep up. They're overworked. They're just like a worker or a factory workers who go on strike, except in the case of the type 2 diabetics, when they're overworked, these cells begin to die. They die just like a type 1 diabetic. And this slow death occurs until the diagnosis of prediabetes. So prediabetes is actually a late phase in this. It's not the first sign of disease. And then now we're going to pay attention to this purple line here. During this time, insulin resistance has had one direction. It's slowly going up. And this slowly going up of insulin resistance is what's making this go down. Remember about that? Insulin resistance is what is driving the death of these cells, these insulin-producing cells in the pancreas. If for some way we can decrease this insulin resistance, these cells can come back. These cells can regrow. They grow slowly, but they can come back. And if we reduce this sufficiently, well, the glucose levels actually can return to normal. So the first message I want to share with you, it's not so much glucose control, because we have our eye on the wrong ball. We have to have our eye on insulin resistance. And then this will go back, and then this will go back. Okay, so what is insulin resistance? This is insulin resistance, right? Okay, this is the mother talking to the child obviously not listening, headphones on. These headphones are insulin resistance. And the mother is trying to tell the child something. And we've all been there, right? She's saying, pick up your room, set the table, take the trash out, some chores, right? And the child doesn't want to hear. But eventually what happens is the mother will raise her voice to the level at which the sound gets through even though she's wearing earmuffs, and the child will eventually respond. That's insulin resistance. That happens to every insulin receptive cell in our body. So, I'm going to suggest to you 5 generic ways that we can reduce insulin resistance. Now, generic means that it may or may not be right for you. Talk to your physician. So, good sleep, get a good night's sleep. How many of you got a good night's sleep last night? All right. Quit smoking. If you smoke, that's actually a cause of insulin resistance. Practice intermittent fasting. Now that's not definitely in the category of not for everyone. Low carb. The ADA actually this year, along with the European Diabetes Association, recommended low calorie diet. And exercise. Now I'm going to actually focus this morning on one type of exercise. And this is the area which I think is fundamentally wrong with how we treat diabetes. So, we're going to talk about resistance training. So, we're going to look at this slide and say, well, what does this have to do with diabetes? This is Joe Acob. He's been in the International Space Station and he's landed on Earth. And he needs help. He needs help getting out of the space capsule because, we all know, he's been in a weightless environment, 0G. He's hardly had to do any work, and his muscles have atrophied, right? We all know this. So, what happens, and this is not quite as obvious, when someone is in space? So this is a study that was done on astronauts going into space. This is actually a Russian published study. So this red line is a glucose tolerance test. Now, many of you are familiar with the glucose tolerance test? Does anyone here not understand what a glucose tolerance test is? They make you drink this very sweet substance, and then they measure your glucose levels, okay? So this guy, our astronaut, super healthy guy, super normal glucose tolerance test. glucose goes up, he actually ends up lower than where he started. What happens within a week of him in space? A week. Losing muscle mass, not having to exercise. Well, look at this blue line. Instantly pre-diabetic. He's pre-diabetic because he had nothing to push against, and his muscles are atrophied. Pretty amazing. This is the fastest way, in fact. The fastest way to become diabetic is to blast yourself into space. Those guys are lucky, aren't they? 3 weeks, up to 3 weeks after they get back to Earth, they're still the same. They still have the same pre-diabetic profile. So, this guy, Scott Kelly. Anybody know who Scott Kelly is? Okay.
Yeah, it was on
Scott,
last night.
Oh, you saw Scott Kelly?
On TV last night.
That's great. So, Scott Kelly sacrificed himself for us. He spent the longest time of any American in space. And he has a twin brother. So NASA did a twin study. So, what happens to lipids to Scott Kelly when he's in space? So, let's look at the blue line. These is pre-flight. Scott Kelly, before he went into space, he's got great lipid numbers. He's got great HDL, he's got great, an LDL that's below 100. He's got good triglycerides. But look at this, 3 months into space, look what happened to him. His triglycerides have more than doubled. His LDL is now, puts him under certain criteria, need a treatment for statins, and his LDL has fallen. That's the relationship between space travel, muscle atrophy, and lipids. So, what's more important is this. NASA knew this. We know this, what happens to astronauts in space. They went an additional step, and they took a look at his arteries. They looked for atherosclerosis in his arteries. Look at this. This is his brother, his twin, who's on the ground. That's his green, the 2 green dots. No atherosclerotic buildup. This is Scott Kelly, 1 year later. Look at the thickness of his arteries. Look at the atherosclerotic buildup. 30% increase. 30%, that's plaque buildup. Okay? So, let's recap. Scott Kelly, normal guy, blasts into space, loses muscle mass, becomes pre-diabetic, has lipid problems, has glucose problems, has atherosclerosis. See a pattern here? Okay. There's the pattern. What happened to him in a period of weeks to months happens to us over decades. His not pushing back against gravity is the same thing that happens to us after the age of 30. This is a process known in medicine as sarcopenia. Sarco means muscle, penia means less. Sarcopenia is the process by which we lose muscle decade by decade after age 30. And it happens, the first thing we notice is a slowing metabolism. In our teenage years and when we were 20s, we could generally eat what we wanted without gaining weight, right? After age 30, we had to begin watching our portions, eating not too much dessert, for example. Then, later in life, difficulty rising from the chairs, difficulty going upstairs, and general loss of energy. That's all because of loss of muscle mass. What happened to the astronauts is happening to us over a longer period of time. So, this two are MRI cross-sections of someone across their the thyroid. It's not a ham steak. Okay. So this is someone who's 30 or younger. And this is someone who doesn't do the type of exercise we're going to talk about. So, if you notice from the outside, since we're not Superman, we don't have X-ray vision, right? They look the same. But if you look at the brown in the center, that's muscle. The muscle has gotten smaller. It's shrunken. That's sarcopenia. But it has not turned into fat. What you see around the outside, that's the fat that's come in to replace it. Okay, so from the outside, things look to be the same. So the guy who says, I can still wear the pants that I used to wear when I was younger, what he doesn't take into account is he's lost a lot of muscle. And for those of you in the front, do you see the dark area right there where the bone is? Can you guys see that? Do you see something that's changed? It's smaller. It's smaller, and that's osteoporosis. And that's no surprise, because what are muscles attached to? Muscles are attached to bone. That's right. So if you have smaller muscles, there's less pull on the bone. And the bone says, well, I don't need to be any stronger, so I'm getting smaller. So that's osteoporosis. Two are related. So, have you ever wondered why the internal medicine doctor sees the same diseases in the same person? They're related, that's right. High blood pressure, hyperlipidemia, or high fats in the blood, diabetes, all these diseases up here, including a good chunk of breast and colon cancer, are all related to the same process. The same process is insulin resistance and related to loss of muscle. Now, isn't that crazy? I think it's absolutely crazy, is that we have a disease process here which is caused by loss of muscle, and we don't treat it. That's fundamentally wrong. Do you agree with me? Since when have you been to your doctor and he says, well, you have insulin resistance, you have muscle atrophy, you need to do something about it? So what used to be the disease of kings, because kings don't have, people do things for the kings, now is the disease of the common person. These metabolic diseases are the result of unchallenged muscle. So, the treatment here is a prescribed, just like a doctor writes a prescription for you. Prescribed medicine, which is exercise training. The best exercise is that which is individualized for you. It's not for someone else. It's like a doctor writing a script, and he says, well, I'm going to write you a prescription, and let's see what the pharmacist gives you how many milligrams. No, he doesn't do that, right? They give you the right number of milligrams for you. The goal here is to restore muscle, or restore muscle metabolism. Metabolic exercise training. Metabolic exercise training is different than other types of exercise training. It's to restore the large muscles and their sensitivity to glucose and to fats. And it's progressively challenging. I see a lot of exercise programs, it's a one-size-fits-all. And that's not the type that's going to make you continuously better. So, I want to change gears and talk a little about, because many of you would say, well, you know, Dr. Shang, I'm older now, I'm in my second half of life, I've never been to a gym, my joints hurt. What are you talking about? Well, look at this guy, Bruce Jenner here. Bruce Jenner, I looked it up, he's 69 years old, right? Bruce Jenner has lost muscle. He can't be, just like we can't be, in his 1976 days winning the Olympic decathlon. We can't be ourselves in our 20s. That's not the point of training. The point of training is not for us to go out and play college ball. Many of us were never like that. I was never like that. The purpose of being in a training program is like this. You have grandchildren who play high school ball, college ball, right? They have coaches, they have trainers. The purpose of them is to guide you. The purpose of being on a team is that you have team spirit. So when they lose a game, the teammates say, hey, you know, got the next one. Or, I know we didn't play that well, but you know, you and I, we can get together, we can play better. That's the purpose of being on a team. And that's why being part of a training program is so important, because we can't always be feeling good about ourselves every single day. Here's another thing. How many of you know this? Diabetic drugs do not stop diabetes. They manage the disease. Okay? If you take diabetes drugs, what happens is, over time, the dose will increase, there will be another one added. That's the natural progression of this disease. If you want to treat diabetes, you have to treat it at a fundamental level. The fundamental level is treating sarcopenia. Starting a good habit. Let me talk about bad habits. Everyone, we can all agree smoking is a bad habit, right? If you went to see a doctor, doctor says, you know, Bill, you smoke. Just quit smoking, I'll see you in 3 months. That's it. That's laughable. That's absolutely laughable. That's what we do. We say, hey, you know, you need to exercise. Here's a Fitbit. Go at it. We need to take our best game to treat this deadly disease. We don't do that for diabetes. I find it utterly bizarre. We know the best treatment. We don't do that. So I want to shift gears and let's talk about the physiology. Some of this, you think science, oh, well, eyes glaze over, but I'm going to keep it simple. So, we actually have 2 types of muscle fiber in every single muscle in our body, with the exception of vocal cords and eye muscles. Some people can jabber on forever. There's no strength in talking. So, we have muscle fiber for stamina and a muscle fiber for strength. There are 2 types of muscle fiber. And one is aging resistant. One which is aging resistant is the one which has stamina. And I'll explain to you in a moment why that's the case. The one that's aging sensitive, the one that leads to sarcopenia, is the one for strength. Okay? It's that simple. So, the one for stamina, you train it with aerobic exercise. The one for strength, you train it with resistance exercise. 2 different fiber types, 2 different types of exercise. Got it? The 2 muscle fibers use 2 different types of fuel. Glucose as the main fuel for strength, and fat for the main source of fuel for stamina. What is the primary problem in diabetes? Glucose management, right? Is it any wonder when we don't train our strength fibers, we have glucose problems? So, the last thing I want to mention here is basal metabolic rate. Basal metabolic rate is determined by how much muscle you have. You increase your basal metabolic rate by increasing your muscle fiber. It's the easiest way to lose weight. Doing it through aerobic exercise is the hard way of doing it. So, I think you remember Ron starting, he said I did autopsies for 3 New York State counties. This is what the muscle of someone who is diabetic looks like. This is actually a pretty expensive cut of meat, but it is not a good cut of meat to have inside your body. This type of muscle cannot burn fat, it cannot burn glucose. This is, I took a picture of this, this is venison actually. This guy gets lots of exercise, right? He's out prancing around, eating your geraniums, my bushes, but he gets lots of exercise. This can burn anything, and the deer, as you know, is a very lively creature. So, muscle quality and quantity are changed by exercise. You change this, you can change that trajectory. So, what is resistance exercise? This is not resistance exercise. Okay, so I want to just take a moment. If I got, see, I want to. This is a real quick one. Get you out of your seats. I need 5 volunteers. I'll take 6 for a real quick 3-minute demonstration. Just come on up here, please. I'm not going to hang you. All right. All right. So, okay. Stay behind this right here.
Stand behind.
All right. There we go. Thank you. Okay. Stand behind this line. Make it go on. Stand behind. Very good. I need one or two more. One or two more. Stay behind the line.
Want to go out?
Okay. Very good.
Yeah, we need, did you need 6?
Yeah, 5 or 6.
Okay,
5 or 6. All right. All right, very good. All right, now, pick up the rope, please. All right, now, everyone see them back there? Okay. we're going to pretend each one of you is a muscle fiber. Okay? Now, I want you to pretend you are a muscle fiber and you're walking. Okay? Now, I want you to gently pull, don't pull me over here. How do you think that the muscle is using you guys? So, pretend like you're up there. How would you pull? How would you pull?
Resistance.
That's right. Okay, stop. Stop. Okay, relax. Okay, that's good because you guys did it wrong. Okay, so the way it works in muscle is that I'm going to come here, maybe up to here. You two were working. You four were not working. Okay, that's how it works. When you do a low resistance exercise, you do aerobic exercise, the guys, the muscle fibers who are stamina type, those are the ones doing the work. These guys didn't do any work at all. They didn't do any work. Okay? So, what happens if you walk up the stairs? Let's see what happens. Okay, sorry, that's still wrong. Okay. Okay, so when we need a little bit more power to walk upstairs, you get engaged now. 3 of us. These 3 guys are working. You 3 are still not working. Okay? So, what happens when the 3 of you in the back don't do any work? This is what happens. You guys are standing around. You're not doing any work. The anaerobic fibers, the 3 in the back, didn't do any work. Now, I'm sorry to tell you this. What happens when the body sees that you 3 aren't doing any work? This is what happens. Okay. All right. All right, let's give them all a hand. Thanks very much. Okay. So, that's why stamina fibers are aging resistant, because they get used more often. And if you think about your daily life, how many times are you using these guys? How many? Not as often. I would say almost never. Almost never. Because this guy at the end who's just dropped off, he never gets called to action. In order for these guys to stay alive and well, you've got to use them. It's use it or lose it. So, that's why you need resistance training. Okay. So what is resistance exercise? It's these guys, okay? And for everybody in this room, there is an exercise. There's no shame in starting pull exercises. Pull exercises are great if you haven't done any resistance exercise, because it's soft and easy on the joints. Body weight exercise is a little bit more challenging. In fact, if you graduate from pull exercise, body weight exercise is the next way to go, and going all the way up here. And Laura Clary is going to help us demonstrate that in our breakout session. So this is just a summary slide, okay? Type 1 exercise, that's a stamina. We do endurance type exercise. Those are aerobic. And we have many repetitions. So the way you think about that is if you're walking, you're doing lots and lots and lots of low resistance contractions, right? Type 2, or the strength, is resistance, and you do very few of those. You need both types of exercise because you have both 2 types of muscle fiber. Okay, got that? Okay. So, the ADA has an exercise recommendation, and it's just that. Now, when I ask doctors, my colleagues, what do you tell the diabetics in your practice, or the pre-diabetics? They mostly respond with this: 150 minutes a week, sometimes up to 300 minutes a week of exercise. Now, how many of you, I'm just taking a survey, I won't beat up your doctors, how many of your doctors tell you you have to do this? This is the ADA recommendation of resistance exercise twice a week. Can I see a show of hands? That's really great. 2. That's a lot more than I usually get. That is the ADA recommendation of exercise for diabetics. And that's the reason. We've talked about the reason now. So that's what's fundamentally wrong with how we treat diabetes. Okay, so there's been many studies that have been done. These studies have shown and been the basis for us producing the best optimal treatment for diabetes with exercise. Every single other realm of medicine, we use best practice. We do not use best practice for treating diabetes with exercise. So, this is my book. I went through, how many of you would like, when you're in that study, you saw the study back here? How many of you would like to have been in that study? That study took people who were diabetics and took them down to the pre-diabetic level. If you were in that study, you would have benefited like that. Okay? So I took those studies, I took the way they did it, put it into a book, and what I'm trying to do is exactly what the funders of this program did, to start a community medical partnership to treat it. Because the medical profession, including the IRS will not allow you to deduct gym membership. When in fact, doing gym exercise is the best way to treat diabetes. It beats drugs. Drugs are not the way to go. So, I'm going to shift gears here and talk about another way of fundamentally treating diabetes. Even though this book is called The Thin Pre-Diabetic, I just could have easily called it Treating Diabetes Through Your Gut. So we're going to talk about just one of these. So we have this rope out here. This rope is, I measured it. Okay, that's about right. This is the length of your small intestine. It's 20 feet. This is the average length, 20 feet. 20 feet of small intestines. It has three parts, duodenum, jejunum, and ileum. You don't have to remember that. This is what you have to remember. The duodenum, short, about this long, from here to the chair, and the rest are split evenly. So, they're called three different parts because they have three different functions, but more importantly, and this is something that's relatively new in our understanding, they have different bacteria. Bacteria make a difference in how we process. In fact, there have been studies that have come out and say more important than genetics is improving our bacteria. We can change our gut bacteria, and that's what we're going to talk about. So this is from my book. I'm not going to talk about all these different ways that nutraceuticals or botanicals can change the gut bacteria, but what the purpose of this is I want to bring into your attention here is that the gut and the bacteria work together and they produce hormones which have metabolic effects. Okay? And I'm going to just share with you one of the methods. One actually you're familiar with. And today, I seem to be talking a lot about fiber. We talked about muscle fiber, now I'm going to talk about dietary fiber. Okay? Dietary fiber is one way you can improve your glucose control. Whether you're type 1 or type 2, it doesn't matter. It has obvious as well as non-obvious ways of improving your glucose control. It has short-term and long-term ways. So, how many of you know what whole foods is? When I say eat a whole food. Okay. All right, so this is a diagram of a grain. Okay, this could be wheat grain, rice grain, doesn't matter. I want you to conceptualize it like an apple. Okay, an apple has skin, right? It has a husk on the outside. And inside, if we were to peel away the skin, we have the meat of the apple. That's called the endosperm. We can think of it like the apple, the meat of the apple. And inside the apple is the core, right, which has the seeds. So, an apple like this, if you break it up, this is the seed and the skin, and this is the meat of the apple. So in other words, we took the apple, we core the apple, and we shave off the skin. That's fiber supplement. Okay? And if we eat the cored apple without the skin, that's processed flour. That's processed bleached flour. Okay? So, if you were to eat the whole apple without coring it or skinning it, that's whole food. That's best for you. If you were to take a fiber supplement, that's like eating just the skin and the core. Now, it's not the best, but it's actually not a bad second best. Okay? So, what happens if we were to take a fiber with every meal? Pay attention to the red line with me, please. So this is what happens after we eat a meal without fiber. The glucose goes up, about 30 minutes later it peaks, and then it makes its way down. Right? That's normal, how we process we're eating, say, white bread. What happens if we add fiber to that? When we add fiber, this peak drops, this green line. Okay? That peak drops, and if we're measuring hemoglobin A1C, what happens if we reduce the highest peak? The average drops. Right, the average drops. So if we eat fiber with every meal, the fiber will reduce the peak and our hemoglobin A1C will drop. It's that simple. And more than that, it'll absorb over a much longer period of time. Why? When we eat unprocessed food, the food gets all absorbed between the chair and here. When we add fiber, the digestion is all the way here. Okay? Now, what happens when you take a look at people who eat fiber for a long period of time? This is over weeks. This is 12 weeks. It's going down. And this is upper line is control. These people haven't taken fiber. But look what happens. This is 6 weeks. It's still going down. It's still going down. How is that possible when we thought the effects were just mechanical? Just prolonging and lengthening out the absorption time. Okay. How many of you have heard of gastric bypass surgery for diabetes? Okay. I'm going to tell you a little secret about this. So, gastric bypass surgery, when the surgeons initially did it, they noticed something absolutely remarkable, is that even before the patients started losing weight, their diabetes numbers got better. How could that be? They're shortening, they're bypassing the parts of the intestines, they're making the stomachs shorter, smaller. How could the numbers improve? That doesn't make any sense. The reason and the secret is that they changed and restored some of the balance of the bacteria to the normal gut. All fiber is not the same, okay? This is insoluble fiber. There's the other type which is soluble, right here. Soluble and insoluble. People who eat fiber can get majority of the benefits without having the surgery. Isn't that amazing? Because they can achieve what the surgery did. Insoluble fiber does what we just talked about. Soluble fiber, certain types of those are fermentable. In other words, they feed the bacteria. They feed the bacteria. And the bacteria, in turn, do great things for us. So, the ADA has a recommendation for fiber. Did you know that? How many of you, before this morning, knew that the ADA had a recommendation for fiber intake? Can I see a show of hands? Okay, that's great. That's about a third of you all. The reason why the ADA has a recommendation is because it lowers glucose control. What the ADA doesn't say is that you should be eating both soluble and insoluble fiber. because eating soluble fiber in particular benefits the bacteria. And I've listed here some of the more of the details. These are basically soluble fibers. So, soluble and insoluble have both types of benefits. They have, for the non-soluble type, for those of you who have trouble with portion control, insoluble fiber takes up room in the stomach. No calories, at least for us. So it takes up room and it makes you feel full earlier than you would normally. It also prolongs the time that it spends in the small intestines, decreasing that peak. Soluble fiber feeds the bacteria. Soluble fiber, by feeding the bacteria, helps restore that normal balance of bacteria to our gut. How does it do that? It restores a historic agreement between us and bacteria. Now, many people disagree about what our ancestors ate. And it was about 10,000 years that we began to grow grains. Before that time, we were hunter-gatherers. Now, I always joke with my wife is that the hunters are gone and only the gatherers are left. But that's, if you didn't get that joke, it's a joke on shoppers. But how do gut bacteria, how does fiber restore that agreement? Paleontologists now believe that the average person, our ancestors, ate between 100 grams and 200 grams of fiber a day. The average person in the U.S. eats between 12 and 15. Let me just let that sink in for a moment. 12 to 15 versus 100 to 200. It's a huge difference. Fermentable fiber in our gut is food for the gut bacteria. That's what they eat. And that, they make nutrients for the cells of the intestines. And they make a hormone called incretins. And the incretins supercharge the insulin that comes out. How much? It's 2 to 3 times. So if you're putting out incretins, then your insulin will be 2 to 3 times as potent. Now, the drug companies already know this, and they produce a class of drugs called GLP-1 drugs. Some of you may recognize these. You can do the same by increasing your soluble fiber intake. Okay? So, I'm going to wrap this up by saying, when you see the next slide, think this, okay? You treat your bacteria right, they will treat you right. Take care of your bacteria, they will take care of you. So, let's see. I don't have my cell phone. How am I doing on time? How many minutes do I have left? 5. Okay, so I have 5 minutes for questions before the break. I'll be here with Laura during the breakout session if there's questions run past that time, but I think I got time for at least 2 questions. So, yes, back there.
What if you're on meds that increase like weight and your risk of diabetes and stuff?
Okay, I'm sorry. Say it again, please.
What if you're on medications that increase your risk of diabetes, like steroids and stuff, and weight gain?
Okay, so what if you're on medications that increase your risk of diabetes, like steroids? And I'll add one more thing to that, and that's statins. Statins increase the risk of diabetes by about 10 to 15%. But there's been a controversy among doctors about this, and among doctors and pharmaceutical companies, the word is that the benefits outweigh the risks, and that patients should continue their medications because the risk of not taking those medications is better than, the risk of taking them is better than not taking them. Now, that said, I have one retort to that. Does anybody know where statins work? what organ do statins affect? Statins affect the muscle. Okay, think about it this way. How many of you have taken statins? Okay. About 20% of people who take statins have muscle pain, right? That's the most common. That's because statins work on the muscle. If you were to exercise your muscle, you would have the same benefit of the statin. So, I would say statins are great, but they're not as good as exercise. Now, to answer your question about steroids, unfortunately, I can't comment about the risk benefit of that. But if your doctor says you need it, then unfortunately, that's what you have to work with. And they do change your metabolism. I'll take this.
What about high fiber diet with diverticulosis?
Okay, so what about high fiber diets with diverticulosis? Now, the studies that have come out, initially when I went to medical school and I finished in 1985, the word was high fiber prevents diverticulosis. Now, the latest studies have been not as favorable. They have not come out and said high fiber will prevent diverticulosis. In fact, they say it probably doesn't. But I would say that we don't really know what causes diverticulosis. So we have theories about it. And I would say that fiber probably doesn't hurt it. Furthermore, that the studies haven't broken down insoluble versus soluble as to what we really need to focus on for diverticulosis. Okay, the question is there a particular fiber supplement that I would recommend for soluble versus insoluble? So I will tell you the recommendations as they stand. The recommendations is to get your fiber through eating food, and whatever you can't do by fiber. Now that's I would say in our day of eating packaged food, if that's your diet, that's very hard to do because the way that the manufacturers extend shelf life is by taking out fiber. So the way to do that is that to have a mix of fiber. Okay, so if you're just eating inulin, that's probably better than none, but it's best to mix it up. So I think this is in this diagram. Oh, here we go. So for diabetics, it's this central right here. Soluble, viscous, and fermentable. If you think this group here, these are what diabetics. I didn't talk about the property of viscous. Viscous is important for diabetics. But these, a mixture of these and this. Now, the studies that have been done with obesity and diabetes, it's very fascinating. I don't know if you've heard about it, I'll briefly mention it. You can take the stool of someone who's thin and transplant it into someone who's obese, and they will lose weight. That's because it's what we talked about. Bacteria are one of the major things you can control beside muscle to control your metabolism. Now, you can take probiotics too, but no one knows exactly what probiotic works. What they do know is this: it has to be encapsulated because it gets destroyed by bacteria. So if you don't take something that's encapsulated, it won't work. And two, it's got to be a mix of bacteria. That's because we don't know exactly what bacteria is the right one. Or maybe it's more than one. Stay tuned.